Crystal, are you ready?
Yes, I am.
Okay. So welcome everybody and good afternoon. Thank you for attending this webinar on muscle and statins organized by EURO-NMD in partnership with European Academy of Neurology and ERN-R&D for rare neurological diseases. Thank you to our today's speaker, Crystal Clays, for honoring us with her presence and for presenting this interesting topic. A little more about Crystal. Crystal is a senior neurologist at the Department of Neurology and Neuromuscular References Center at University Hospitals Leuven, and she's assigned as a professor at the Department of Neurosciences in Leuven in Belgium. She's heading the laboratory for muscle diseases and neuropathies. Our research topics are clinical research and genetics in neuromuscular disorders with a focus on hereditary muscle diseases. Crystal is also a board member of the European Reference Network for Rare Neuromuscular Diseases, EURO-NMD, and coordinator of the subnetwork for rare neuromuscular diseases as part of the Flemish Network for Rare Diseases. So today's webinar will cover the wide range of potential muscular complications caused by statin. Diagnosis and treatment will be discussed using Clay's presentation and literature data. So thank you again, Crystal, and the floor is yours. You can share your screen.
Can you see my screen, Elisabeth?
Yes, yes, we see your screen.
Okay. You can see my pointer?
Yeah.
Okay,
also.
Great. Okay, Elisabeth, thank you very much for the nice introduction. And so indeed, the topic of today is muscle and statins. Now, what are statins? Statins is medication. They are medicines that inhibit the 3-hydroxy-3-methylglutaryl coenzyme A reductase enzyme, or shortly HMGCR enzyme. And this HMGCR, it's an enzyme that is involved in the biosynthesis of cholesterol. Now, the purpose of taking statins is because they reduce the low-density lipoprotein, LDL, cholesterol in the blood. And the background, so why it is given, it is because an increased LDL cholesterol is an important risk factor for cardiovascular and cerebrovascular accidents. There are several statins available. The first statin was lovastatin in 1987. That was the first registered statin. Serivastatin is a statin that has been taken from the market because there were a large number of complications, severe complications with rhabdomyolysis. It was under the names of Baycol and Lipobay, but so no longer available. And then the others that we know well. They have different properties. Especially important will be the half-life of the statins. You can see that, for instance, atorvastatin and rosuvastatin, they have long half-lives, and there are others like fluvastatin that have short half-lives, and that will be important later on when we discuss the side effects. Also, the metabolism pathway is different for the different statins. So you see that atorvastatin, lovastatin, and simvastatin, they go through the CYP3A4 pathway, but then you also have other statins like fluvastatin and the others that use another metabolic pathway, and that also will be important for in the context of the side effects. Some of them are fungal from origin, and others are synthetic from origin. Now, statins have favorable effects in the primary and the secondary prevention of cardiovascular events and stroke. They cause a reduction of 10% of all-cause mortality, 15% reduction of cardiovascular mortality, 19% reduction of stroke, and 23% reduction of coronary events. Important is to put the use of statins a little bit in context in the sense of the use, the number of statin users, and also of the costs of statins. This is an example in Belgium because, of course, I work in Belgium. So these are numbers from the National Institute for the Sickness and Invalidity Insurance in Belgium. And you can see that over the years, the number of statin users has really increased largely, up to 1.5 million users in 2016 on a total population of 11.5 million, which is really a huge percentage. If you look at the expenses in Belgium for the statins, you can see that in 2011, that was 250 million euros per year. And nowadays it's around 150 million euros, which is 5% of the total of the total medication budget. Now here, this decrease is due to the introduction of the generic medications, which are a little bit cheaper, but still this budget is very huge. This is the same graph, but from 1997, where you even see the increase is much more impressive. Here you can see also what statins are used in Belgium. You see that some are increasingly used, others are less used. Like for instance, atorvastatin is less frequent, and rosuvastatin, for instance, a little bit more frequent. And here you also see the distribution of age of statin users in Belgium, where you see that it's not really only the patients that are quite a little bit older, but also younger patients, as you can see here, 35, 45 years of age. Now, the statin use of statins, it is really a big topic of discussion, as you can see here in this cartoon and also in some publications, that, there is a lot of pro, a lot of contra, and this subject is really unsolved. It remains really a big subject of an issue of a discussion, but of course we will not go into this discussion, but this topic or this webinar will mainly go on the potentially harmful effects of statins. So they are not only beneficial, but certainly have quite some potentially harmful side effects. And that's what we will talk about. If we look at the incidence of or the frequency of the side effects, you see that the skeletal muscle is the location where the most frequently side effects in 10 to 15% of the patients are reported. There are also others like new onset diabetes mellitus, for instance, and others, but we will focus today on the side effects on the muscle. The underlying mechanisms of these side effects are multiple. One of the mechanisms is the mitochondrial pathway that is affected, but also impaired calcium handling, impaired membrane stability, and so on. Now, the statin-related myotoxicity, or SRM, is used as this classification from SRM, so statin-related myotoxicity 0 to 6. And so one, for instance, SRM1 is more frequent than SRM6, but the severity also increases. So SRM1 is much milder than SRM6, for instance. So you have an increasing severity and rarity from 1 to 6. So the statin-related myotoxicity, or SRM0, here you only have a CK elevation of less than 4 times the upper limit of normal, and you will have no muscle symptoms in the patient. When the patient has a myalgia that is tolerable, so for which he does not really need to take pain killers, so where they have muscle symptoms without CK elevation, this is the stage SRM1. If the myalgia are intolerable, so they need really painkillers, so it's a really severe myalgia, and CK is less than 4 times the upper limit of normal, then this is SRM2. In case of there is a myopathy with CK elevation between 4 to 10 times the upper limit of normal, with or without muscle symptoms, this is SRM3. A severe myopathy with a higher CK values and muscle symptoms will be SRM4. And then we come to the two more severe side effects on the skeletal muscle. That's rhabdomyolysis, so where CK is very high with muscle symptoms and renal impairment. In some cases, this is SRM5. And the SRM6 is the autoimmune mediated necrotizing myositis, where there are the HMGCR antibodies with incomplete resolution after stopping the statin. So incidences are very variable from in the literature. So between publications, it will be very variable, but we know that these type 1, 2, 3 are more severe than, for instance, type 5 and more frequent than type 5 and 6. Now we will consider type 1 to 5 together because these SRMs are self-limiting, and we will put them against SRM6, which is not self-limiting. And this is shown here. So we have the self-limiting statin myopathy, SRM 0 to 5, and then the statin-induced necrotizing myopathy, SRM 6. So these are relatively frequent, whereas the statin-induced immune-mediated necrotizing myopathy is rare. Proximal muscle weakness is uncommon in the self-limiting forms, but is very common in the immune-mediated form. Maximum CK value here in these self-limiting forms, it's normal to a slight elevation. And of course, in SRM5, where there is a rhabdomyolysis, of course, it can be high, the CK value. And we know that in the autoimmune form, it will be several thousand, so between 1,000 and sometimes 50,000. There are some genetic risk factors for both. So here in the self-limiting statin myopathy, there has been a single nucleotide polymorphism, or SNP, has been identified as a risk factor in this gene. And we know that this HLA allele, so patients that carry this allele have a higher risk to develop this statin-induced IMNM. The time course, so the self-limiting statin, so between 0 and 5, they are self-limiting, so that it will resolve after discontinuation of the statin. But it's important to keep in mind that it can take several months before there is a clinical resolution, and also before the CKs are completely normalized. Here, and the autoimmune myopathy, stopping the statin alone will not be enough to treat the disease. So the disease will continue even after stopping the statin. So it's not self-limiting. The HMGCR antibody will be absent in SRM 0 to 5, but will be present in SRM 6. EMG and MRI can be normal. Here is usually normal in 0 to 5, but will show an irritable myopathy, so myogenic changes with some spontaneous fiber activity, and will show muscle edema on MRI of the muscles in SRM6. Muscle biopsy here will be non-specific, whereas in SRM6 it will show necrosis and either no inflammation or just a little bit of inflammation, but the necrosis is really most predominant. And treatments in the self-limiting forms will be to stop the statin, whereas in this, in the SRM6, in the autoimmune myopathy, you will have to stop the statin, but also start immunosuppressive therapy. We will focus now on the SRM, so the statin-related myotoxicity 6. And this is a subgroup, or it belongs to the larger group of immune-mediated necrotizing myopathies, IMNM, or also called necrotizing autoimmune myopathy, NAM. So this group, IMNM, is a part of the larger group of idiopathic inflammatory myopathies. Within the inflammatory idiopathic myopathies, there are subgroups, and so IMNM is one of them. There's also the antisynthetase syndrome, dermatomyositis, and inclusion body myositis. This is shown here. So we will look at the necrotizing myopathy, of which HMGCR is one of the antibodies that can be involved, but there's also SRP, for instance. And besides this group of idiopathic inflammatory myopathies, there's also the antisynthetase syndrome with also other antibodies that are involved. There is the dermatomyositis with, again, other antibodies, and there is the inclusion body myositis. So we will focus here on this part. So immune-mediated necrotizing myopathy is 20% of the whole group of idiopathic inflammatory myopathy, and there are antibodies either against HMGCR or against SRP, signal recognition particle, or in 30 to 40% of the cases, the antibody is not known and it will be a seronegative case. So in the cases with antibodies against HMGCR, it's important to realize that many patients have taken statin, but not all of them. So around 65% of the patients will have taken statins before, or related drugs before, or at the time of the diagnosis, whereas 35% of the patients will have never had any contact with a statin. Previously, this antibody was called anti-200 autoantibody, and you see, so it is, you can see the band here at around 100 kilodalton. That's the protein, and now it is called anti-HMGCR antibody. This is an interesting study where many patients, so where they looked at positivity for anti-HMGCR antibodies, and they looked in different entities like IM, the autoimmune necrotizing myopathy, but also polymyositis, dermatomyositis, juvenile dermatomyositis, also in a group of healthy subjects. And they looked at the frequency of these antibodies in these different subgroups. And they found that in 38 of 69 patients with IMNM, there were HMGCR antibodies, so that's around 45%. There were also HMGCR antibodies in poly and dermatomyositis and juvenile dermatomyositis, meaning that this is not completely specific for IMNM. If we look at the portions of, so if here you can see 48% of, so these are all patients with the antibodies, HMGCR antibodies, and 48.4% have the phenotype of IMNM, 28% of polymyositis, 15.6% dermatomyositis. There are also a little bit of juvenile dermatomyositis, and there was one patient with a primary Sjögren's syndrome and one patient with a systemic lupus erythematosus. So it's not only in this subgroup that these antibodies are found, but it is the most frequent group. If we look at the idiopathic inflammatory myopathies in total, we find in 5% of the patients HMGCR antibodies. If we look specifically in the subgroup of IMNM, it is 44.9. If we look at this subgroup, but also patients taking statins, it is 68.9% of the patients that have these antibodies. And if we look in the subgroup with using statins and older than 50 years of age, you see that it is even more in 76.5% of the patients having these HMGCR antibodies. Now, how looks the muscle biopsy in this disease of immune-mediated necrotizing myopathy with these antibodies? We have a necrotizing biopsy, so we find necrosis and we find regenerating fibers. We usually don't find a lot of inflammation. So we see here CD68, which is a marker for macrophages, and you can see here that it stains very positive, that are the macrophages that are involved in necrosis of the muscle fibers. If we use markers against lymphocyte like CD8 or CD20, we don't see inflammatory cells that are staining. We do see an intensive staining with the MHC1 staining, where you can see here the dark brown fibers and membranes that are staining positive, meaning that there is an inflammatory process going on. And also in this disease, we will find C5b9, so that's the complement pathway. We also see deposition at the membranes of complement in this disease. So this disease is characterized by complement activation. So there will be a complement-dependent muscle damage. So there will be an activation of the complement, and membrane attack complex will be destroying the muscle fibers. So there will be a necrosis of the muscle fiber, and there will be from the myoblasts, so the regeneration will be done. And on the regenerating muscle fibers, the HMGCR antigen is presented or expressed at the surface. Normally, HMGCR is only present at the endoplasmic reticulum inside of the muscle fiber, but in regenerating fibers, we find it on the membranes. And that's also the explanation why this process is continuing, why the process is not stopped just by stopping the statin, because you really introduce here an inflammatory process that is not stopped just by stopping the medication. So, association with statin use, I told you that not all patients with this disease have taken statins before. It depends on the literature, but it is between 15 and 94% of the patients that have used statins at the time of the diagnosis or previously. In patients more than 50 years old, this will be a little bit higher in several publications. So patients that never took statins before or had never had any contact with statins or related medications are younger usually and are less therapy responsive. So the disease can occur with any statin. It can occur relatively rapidly after starting the statin, but it can also occur many years after the statin has been started. And that's also why sometimes this diagnosis is missed, because people already take it for years and the symptoms only started recently, and people think that this cannot be related. So it's important to know that there can be a delay of symptoms of many years. It occurs more frequently in females. The age at onset is between 1 and 83 years, with a mean of 50 to 58 years. So important to realize that also children and adolescents can have the disease. The initial course is subacute to chronic. And in most of the patients, there will be muscle weakness, which is mainly proximal in distribution, which is frequently severe, with a wheelchair use of 25% of the patients during the disease course. Dysphagia in 63%, and respiratory symptoms can also occur, but are usually mild. Myalgia also in 75% of the patients. There can be some systemic symptoms like arthralgia, skin rash, interstitial lung disease, and Raynaud phenomenon. There is usually no cardiac involvement, in contrast to, for instance, the SRP-related immune-mediated necrotizing myopathy, but usually here in this disease, we don't find cardiac involvement. And malignancies is reported to be maximum 11%, so a factor of 2.6 compared to normal population. And the type of malignancies are very variable. This is a study of the disease in childhood, clearly in patients who never had contact with a statin. So they looked at pediatric patients with clinically and/or pathologically suspicion for inflammatory myopathy, and they had a group of 62 patients fulfilling these criteria, and they found in 9 of the 62 patients, so in 15% of the children, they found HMGCR antibodies. So here those 9 patients are indicated, and you see that the age of onset varies between 10 months up to 13 years. So it can be very young children as well, with a presentation of just of difficulty climbing stairs, muscle pain, myalgia is also frequent. Asymptomatic high CK can also occur, also fatigue, so difficulty climbing stairs. And as you can see, the initial diagnosis is like congenital muscular dystrophy, So it can be really a wrong diagnosis, especially in children where it's very difficult to make this diagnosis. Disease course is subacute to chronic, and you see that CK is largely elevated in these patients. So in the study, they conclude that pediatric necrotizing myopathy with these HMGCR antibodies is not as rare as we might think. Antibody testing should be considered for children that are suspected to have an undiagnosed muscular dystrophy. And early diagnosis of pediatric necrotizing myopathy due to HMGCR antibodies is crucial for outcome. And this is also shown in this study, where the several patients that were considered to have a limb girdle muscular dystrophy were later on to be shown to have those HMGCR antibodies and to have an autoimmune necrotizing myopathy instead of the muscular dystrophy. So here you can see the MRI of the thighs. The MRI of the calves of patient 2 to 6, all diagnosed with an HMGCR myopathy and previously diagnosed with a limb girdle muscular dystrophy. You see here the current age and the disease duration. So the first patient is currently 12 years old, and the disease started, or the symptoms started, at the age of 8 years. So this is a child, and these patients are adults. But you see that the disease duration can be really very long. So the delay of making the diagnosis can be very many years that those patients are not diagnosed. And of course, what you see on the MRI is that with increasing duration of the disease, there is damage of the muscles, especially of the hamstring, so the posterior compartment of the muscles, and also of the anterior part after some many years. And of course, this is a situation that is no longer reversible. So if the diagnosis is not made early, and if the disease is not treated early, you get muscle damage that is no longer repairable. So permanent muscle damage in case of long-term under or no treatment results in irreversible muscle weakness. So the early recognition and treatment are important. And the most important differential diagnosis is the muscular dystrophies, also endocrinopathies, especially thyroid disease, and metabolic myopathies. There are several risk factors that have been reported, especially advanced age, female gender and a low body mass index, also chronic kidney and liver disease, hypothyroidism. Also physical exercise can be a risk factor to develop the necrotizing myopathy due to the HMGCR antibodies. A personal or a family history of muscle pain and elevated CK, because we know that statins can trigger symptoms of a previously undiagnosed myopathy. So this, if you have, if the patient has this before you start the statins, you should first, you should be aware of perhaps there is another muscle disease or going on in this patient. This allele we already talked about, so that is also a risk factor for this disease. And the statin dose, so the higher the dose, the risk will be higher to develop the disease, and also statins with a longer half-life. For instance, atorvastatin and rosuvastatin have a longer half-life, will give more problems, like for instance, compared to fluvastatin. Then, of course, other medications that will use the same metabolic pathways, like the CYP3A inhibitors, like cyclosporin, amiodarone, etc. this is particularly the case for atorvastatin and simvastatin, because they also use this pathway. For fluvastatin, it could be an interference with inhibitors of the CYP2C9. And also important as a risk factor could be the fibrase, cyclosporin, so medication that inhibit the OATP1B1. So we know that statins can cause a worsening of symptoms of a known myopathy, but it's also the case that statins can trigger the first symptoms in patients with a so far undiagnosed myopathy. And that's especially true for myocardial disease, so GSD type 5, so glycogen storage disease type 5, also CPT2 deficiency, and for instance, recurrent childhood rhabdomyolysis. There are several muscle diseases that have been reported to be triggered by the use of statins. So what could be very relevant, that is measuring the creatine kinase in the blood before the start of the statin intake. Because if you have an increase in CK at the time of statin intake, and when there are possible side effects of the statin, you don't know, you should be able to compare with the CK value before the start. And if the CK value before starting the statin is already elevated, you should always think that perhaps there is another muscle disease underlying in this patient. Now, what about treatment in this disease? So the first thing to do, of course, is stop the statin. Then you will start corticosteroids at a high dose of 1 milligram per kilogram per day. You will also start preferentially another immune suppressant, that is methotrexate, azathioprine, or mycophenolate mofetil. The doses are mentioned here. So you will start this at the same time approximately, and in order to taper the corticosteroids afterwards. In very severe cases, this will not be enough, and you will have to use other therapy like plasmapheresis, plasma exchange, or rituximab, or intravenous immunoglobulins. This is a publication of the ENMC International Workshop, where also this treatment has been discussed. And here they make a distinction between non-severe and severe HMGCR myopathy. With severe, they mean walking difficulties and or dysphagia. And so the first step is steroids. Intravenously, especially in severe cases, and perhaps also in non-severe cases, but especially the oral steroids, 1 milligram per kilogram per day. And at the same time, or within 1 month, you start a second agent, being preferentially methotrexate, which could be given orally or subcutaneously. And if there is an intolerance for methotrexate, you could start azathioprine or MFM. Intravenously immunoglobulins is also recommended, but it's important to know that this is not reimbursed in all countries for this indication. Also in Belgium, IVIG is not reimbursed, so we are not allowed to start this treatment in these patients. But if it is reimbursed, of course, it's a very good treatment in these patients. And of course, if it's very severe and this medication does not help enough, you can go to rituximab. So this is the initial treatment, and then the maintenance treatment. So the purpose is to taper the oral steroids to the lower dose, lowest dose as tolerated as soon as possible, and to continue the methotrexate at least until 2 years of well-controlled disease. And then afterwards, you can try to taper, but you have to keep in mind that there is a high risk of relapse in this disease in case of tapering corticosteroids and or immunosuppressants. In case you use rituximab, you can continue rituximab every 6 months for at least 2 years of up to at least 2 years of well-controlled disease. So management of this disease, so you stop statin intake, you start immunosuppressive modulating therapy as soon as possible. you follow up the therapeutic effect by the clinical exam, so muscle strength examination and serum CK, which will lower if the treatment is beneficial. And then, of course, physiotherapy is very important. So additional physiotherapy, physical revalidation, and in some cases, when there is dysphagia, of course, also swallowing therapy. Now, important to know is that after 2 years of treatment, less than 50% of patients have completely recovered, and meaning with completely recovered, having a normal muscle strength. So this is, I think, quite low, meaning that it's really a severe disease. And for the future, what might be interesting is that there has been a clinical trial with the C5, so a complement inhibitor, zilucoplan, so there could be a potential role in the future for complement inhibitors in the treatment. So for the management, this is a schematic representation of the different statin-related myotoxicity subgroups. So if your CK is normal or less than 4 times the upper limit of normal, and you have no myalgia, so if the CK is slightly elevated, but you don't have any symptoms of myalgia, it's SRM 0, and then you just continue to monitor. So clinical examination of muscle strength and CK measurements. If there is either normal CK or slightly elevated with myalgia, then you have the statin-related myotoxicity type 1 or 2. Then you could stop for 2 to 4 weeks and try a re-challenge where you could perform a doses reduction, or you could also switch to another statin with a shorter half-life, for instance, fluvastatin. Or you could also change to another drug class, of course, like ezetimibe, fenofibrate, cholestyramine, or the newer PCSK9 inhibitors. Now, if your CK is more than 4 times the upper limit of normal, then you come in the group of statin-related myotoxicity type 3 or 4. Then you could stop for 6 to 8 weeks. If after 6 to 8 weeks there is still a deficit, or your CK value does not return to normal, you probably have to do with SRM type 6, and you need to test the HMGCR antibodies. If these HMGCR antibodies are present, you will not do a re-challenge, but you will change to another drug class preferentially. But you will also, of course, do for diagnostic, you will do the biopsy in case that the antibodies are positive for confirmation. If the antibodies are negative and you have a persistent CK elevation with symptoms, you will have to look for underlying differentials. And for this, you will also most probably perform a muscle biopsy. Then you have the SRM5, so rhabdomyolysis here. It's the same as for SRM6, so you will also stop for 6 to 8 weeks. If there is a deficit, we have the 6, but if it returns to normal, so your CK returns to normal and you don't have a deficit, at that time you could do a re-challenge. So we will not do a re-challenge in case of antibodies, but in the other cases you could try a re-challenge. Now I will present you this female patient of 90 years old with a hypercholesterolemia. And so at age 84 years, she had a rhabdomyolysis with CK of 65,000 due to the intake of simvastatin. She had very pronounced walking difficulties, generalized muscle weakness, and it was so severe that she had to be hospitalized. Simvastatin was stopped and there was no treatment given. And we saw that after 2 months, the serum CK was normalized and there was a clinical recovery. So the muscle strength recovered completely after 2 months. In this patient, the statins were not restarted, or other cholesterol-lowering medication were not restarted. Well, I think especially because of the age and perhaps other arguments. But anyway, at age 86 years, the patient reads in a popular magazine the possibility to take something for her against the cholesterol elevation in her blood, and it was announced as a naturopathic food supplement named cholecystol. So she starts this treatment and at 1 year later, at age 87 years, she develops pronounced proximal weakness with walking difficulties, myalgia, dysphagia, and CK of more than 6,000 units. She was again hospitalized because of the severity of the symptoms, and this cholecystol was stopped. HMGCR antibodies were shown to be positive, and high-dose corticosteroids, methotrexate, and plasma exchange was started. And so only after 2 years, there was a normalization of CK with only a partial recuperation of the muscle strength. Now, what is this cholecystol? This is one example, but there are many products available. They can be bought online, so you don't need a prescription. And these are all red yeast rice products. Now, what is red yeast rice? It's a fermented food product in Asia, and it is used in traditional Chinese medicine. And it is advocated as an alternative therapy for hypercholesterolemic patients that refuse statins or that cannot tolerate statins, or they want to have something naturopathic. The Monascus purpureus is the yeast that is involved, and you can see here how this is prepared. So this is a rice that is water saturated, will be steamed, and will be cultured together with the Monascus purpureus, so the yeast. This will be cultivated, heat dried, and then you get this rice that looks red, so the red yeast rice. Now the red yeast rice contains monacolin K, and monacolin K is identical to the active substance of the medication lovastatin, which is a statin. It lowers the LDL cholesterol in blood by inhibition of the HMGCR enzyme, and the side effects are identical compared to the statins. Now, what is the problem with these red yeast rice products? That is that they, although they have the same content of lovastatin, so as a statin, they are not catalogued as medicines, but they are catalogued as food supplements, which means that they do not have to fulfill the very strict criteria and that are valid for medication. So therefore, there is no strict quality control, as is the case with medication, as for instance, the statins. They contain a very variable amount of monacolin K. There is no standardized measuring method. And they also contain a nephrotoxic mycotoxin, which is called citrinin, and which can cause renal insufficiency. But so the problem is that you don't need a prescription. It is available online, and so patients can just buy it, and they do not have any medical follow-up. So then I come to my conclusions. Statins, they cause skeletal and muscle side effects in 10 to 15% of the patients, with rhabdomyolysis and immune-mediated necrotizing myopathy as the most severe presentations. Statin-induced immune-mediated necrotizing myopathy is associated with HMGCR antibodies and is not self-limiting. So an early recognition and a rapid start of immune suppressive therapy is necessary to avoid remaining muscle damage. The red yeast rice products contain the identical active substance as lovastatin, so as a statin, and can cause identical side effects as a statin, including the immune-mediated necrotizing myopathy. So they are not an acceptable substitution for statins. And of course, important is a shared discussion with a good informed patient to consider always before starting a statin the pros and cons of the medication, and especially also to consider other possible measures, like for instance, lifestyle changes, if possible. So I thank you for your attention, and I'm happy to take your questions.
Hi, Crystal, thank you very much. Sorry I couldn't be earlier here, but I trust that Elizabeth replaced me with advantage. Thank you for your presentation. I don't see for the moment any question in the chat or in the Q&A tool, but that's not unusual, so people have some warming up to do. Everybody is now unmuted, so if you want to voice your question, you can. I'm starting with a provocative question. You gave a very good algorithm on how to deal with the problems of the use of statins and the risk of developing myopathy, which is very useful for everyday life. But I think that we could explore that side a bit more. So, for instance, the lady with 84-year-olds that you talked about and whose case you presented, how deep is the need for a statin at that age, or even another treatment for cholesterol, when we know that statins are basically undoubtedly acting on a biomarker, the cholesterol level, but we are not sure, namely when you're 84, what repercussion that will have on your survival?
I agree completely. And so in this patient, she actually only, just to be clear, the statin was not started by us as neurologists. But indeed, so she has a increased cholesterol. She did not have diabetes. She did not have a cardiac stent or a cardiac infarction. So really, in this case, I think if it's only this increased cholesterol, there are other alternatives, and I also in this case would not start a statin. The discussion is more difficult in patients that are followed by the cardiologist because they have a stent, a cardiac stent, or because they had a cardiac infarction. And well, in my experience, this discussion is always very difficult between the neurologist and the cardiologist because, well, I think the cardiologists only see the advantages and we only see the disadvantages. So it's a very difficult discussion. And I think, well, there have been books written on that, the pros and the contras of statins. So it's really, so that would, well, so in this case, to answer your question, I would not start statin. And of course, not red yeast. I would never use red yeast. It's really not recommended to use it, but you can just buy it. So it's not recommended, but you can. It's not forbidden either. So you can just buy it on the internet. But I think as a doctor, you should never advise to take red yeast rice products.
Yes, I agree. All those natural treatments that are so easy to sell to patients that don't take other treatments just because they come from the pharmacy is a phenomenon of our days. Is a kind of Facebook, Twitter event. But then again, should we tell our patients or even our colleagues in cardiology to use alternatives to statins after some age? What do you think about that?
Well, I think nowadays there are also many alternatives. So now you have this new group of medications in familial hypercholesterolemia. So I think, first of all, a diet should be tried. That's the first thing. People should lose weight. And if that's not possible, you could start, for instance, with a fibrate, like fenofibrate or ezetimibe or another substance. I would not go for the statin in these cases, in these patients.
Mm-hmm. Okay, yes, I agree with you. And I'm going to look. Does anyone want to put any question? You can write or you can unmute yourself. Okay, so in cases that you have had clearly some repercussion, like a necrotizing myopathy that is rather severe, if you consider that it may occur in a patient with high risk of vascular disease, what kind of, apart from your algorithm, what kind of extra precautions or recommendations would you give to limit the risk of recurrence of another complication like that?
So I think you could, if you have to start a statin anyway, it would be best to take one with a lower half-life. And you should give or prescribe the lowest dose of the statin. Okay? And of course, you should take a CK value before you start the statin, and you should monitor it very closely during the treatment.
So how frequently would you take the CK? Every 6 months or more frequent?
Yes, I think 6 months would be good. Of course,
okay.
There are no really guidelines about that. That's just how I do it.
Yeah, right. So in terms of patients with complex overlap of kind of metabolic syndrome with an overlap of endocrinological and vascular disease, sometimes the treatments may have reduced effect, even if they are used in the usual acceptable dosage. Although this is not an exactly linear dosage response case, would you have any recommendations for those cases? Have you seen many cases where that type of extreme overlap of diseases may be a worry and a factor for the production of the myopathy?
So an overlap with what diseases?
Diabetes, with vascular disease and renal disease.
Well, of course, these are the risk patients where the cardiologist or diabetologist they will start statins. That's the group of patients that they certainly want to start statins. But of course,
how often do you see them?
With complications?
Yes, of course. Yeah.
Well, if I only look at the SRM6, so the HMGCR antibodies, I'm following for the moment around 25 patients actively follow up. So it's not so rare. And the thing is that most of the patients, if they come to the consultation, they have never been informed on these possible side effects. So I think it's important also to talk when one starts a statin to talk with the patient about the pros and contras and the possible severe side effects that can occur. Because some of these patients, they come at a consultation in a wheelchair because they are so very much severely affected. So I think the patient should be able to decide together with the doctor if this is a risk he wants to take by taking statins, because none of those 25 patients have ever heard at the time they started the statins that there could be such a severe complications.
Oh, so that's an interesting message indeed. Okay, so apparently people are quiet today. I think that everybody must be tired by now because it's late in the day. I probably will finish, and thank you very much, Crystal, for your presentation. I think it was a very important presentation and it gives very important messages, because although the occurrence of the myopathies related to statins are not completely alarming in the sense that they don't occur every day, the fact is that they are severe and they are not so rare, and people need to have some rules for the use of the medication in the most beneficial way. Do you want to say anything else?
No, thank you very much for the interesting discussion.
Okay, so we'll meet very soon, I'm sure, and thank you for your time and your patience. Thank you. Thank you all for being present. Bye now.
Bye-bye.